stuff. So just to reiterate, I'm going to be presenting on contingency management today and joined by my postdoctoral fellow. So for those of you that aren't familiar, ASEP is the Addictions and Substance Abuse Program. That is a specialty clinic affiliated with the University of New Mexico Hospital. And we do run a contingency management program. And so I really thought that it was important to have Dr. Keeling and Alisa Damholt here with me today because particularly Alisa has been instrumental in helping roll out our contingency management program. So Dr. Keeling and I are going to present a lot of the sort of typical lecture material so that you have an understanding of what this is, the theory behind it, and some of the evidence that supports it. And then at the end, there'll be hopefully ample time for us to talk about how we implemented our program, some of the lessons that we learned, some of the things to consider, and then answer any questions you guys have in terms of how you might be able to apply this evidence-based program at your particular site. So that's really our hope for today. So we're going to provide you with a little bit of history on what contingency management is, why it's good to use it in case you don't know that already, the learning theory behind it, particularly classical conditioning, and really why reinforcement works the way it does, both to shape addictive behavior and also to shape recovery-based behavior, right? So helping to really understand how contingency management can take the same processes that got someone into the position to become addicted to the substance and help them to learn new behaviors to counteract that. Then we'll talk a little bit about implementing a contingency management program and review a lot of a sample of the research that supports it. And then, like I said, at the end, there'll be a lot of time for us to facilitate a discussion and any questions that you have about how to implement this thing. So guys, just jump in if you have any thoughts, and we'll just kind of go back and forth as we move through this content. So the history of contingency management, well, a lot of you mentioned that you were really interested in this particular intervention because you work with individuals, particularly with methamphetamine use disorder, and to understand that this program really developed, or the series of interventions developed out of the need for effective treatments, particularly for cocaine use, but has now been applied very effectively to methamphetamine use. So thinking back to sort of the beginnings of structured evidence-based programs for substance use disorders, the bulk of them were focused on folks with alcohol issues. And then later, when methadone became more commonplace and MAP programs became disseminated, there were structures in place to support patients with alcohol and with opiate use disorder, but not so much with stimulant use disorder, particularly with cocaine use. And we were seeing a lot of patients come in around the 80s with cocaine use, comorbid with their alcohol use. And they were really failing out of the treatments of the day. And they were labeled as particular substance use programs like to do to blame the patient, to really say that it's their fault, that it's not working, it isn't the treatment. But then a group got together and started to figure out, actually, there might be something different about stimulants and how it's affecting the patients and why the treatment as usual isn't working the way that there are some unique factors associated with stimulant use disorder that need to be accounted for and that are not addressed by standard treatments that we would use for other substances of abuse. And one of the things that we're aware of is the fact that stimulants really hijack the dopaminergic system. So the part of the system that is responsible for learning is what's getting tapped into when somebody is using a stimulant. And we'll talk a little bit more about that when we get to the learning theory. So essentially, a lot of these patients were dropping out of treatments, and researchers started to figure out, well, we need to do something different. So a group of behaviorists actually got together, and they decided to look at what might be an effective approach to provide more positive treatment outcomes. And thus contingency management was born. And it's been proven effective not just for stimulant use disorder, but actually for all substances of abuse. So that's something to keep in mind. This is the recommended intervention for people with methamphetamine or cocaine use disorder, but it could be applied to any substance use disorder. And in fact, that's how we've implemented it at ASEP. We don't limit it by substance type. It is now considered to be evidence-based by NIDA, and it is endorsed by the U.S. Surgeon General as one of the treatments of excellence. What we would say, even though there is a fair amount of organizational need to run a contingency management program, and honestly some budgetary issues that you need to consider to be able to roll something like this out, it is considered to be an essential component of effective substance use treatment. So thinking about how you can apply it is hopefully what we can focus on at the end of this conversation. What might be some ways that maybe you're not going to implement the entire contingency management program, but you could start to think about utilizing learning theory and schedules of reinforcement to reinforce the behaviors that you want to see more effectively. Because really what it's geared to do is help the patient overcome what's happened to their brain because of the long-term stimulant use. So now let's shift into learning theory. Did you want to take this one?
Oh, sure, yeah. So, so in terms of kind of thinking about how that reward system, the learning system, the dopaminergic system is being hijacked by substances of abuse, learning theory can give us some insight into like how that actually has shaped their prior drug use behavior over the course of the journey of drug use, as well as help provide us an opportunity for how patients can actually shape and learn new behaviors. And so it's basically a great framework, if you will, for understanding sort of how patients maybe went down the road of drug use initially, and then how that might have led to addiction. And then also a great framework for basically can be leveraged essentially to help reinforce those behaviors that we want to see more of. So contingency management is really going to be focusing on rewarding or giving that positive attention to the effective behaviors that we want to see more of from our patients in order to increase those effective behaviors or those helpful behaviors.
So for those of you that aren't familiar, we're going to explain what a reinforcement is.
Yeah, so this is one of the, there's lots of ways that reinforcement can work, but one of the things that we do know is that behavior change of any type is actually very challenging. And that, one of the ways to help people make those very challenging changes in their behavior is to focus on the types of reinforcement that might lead to increases in behavior that we want to see more of and decreases in behavior that we want to see less of. So this is, just a nice 2x2 matrix. But if you can see where the two large positive signs are, those are like the happy places where we want to be. And the contingency management really focuses in that upper left quadrant, which is the positive attention, essentially catching a person doing something good, something that you want to see more of. And by rewarding or attending to that behavior, what we see is those effective behaviors increase. And if we look right below that, actually not attending or rewarding to the behavior, letting those sleeping dogs lie, can often actually lead to effective behaviors decreasing. So, so this is where, learning theory can really be helpful to say, actually, we do need to spend some time rewarding or attending those behaviors that we want to see more of. And then considering as well that another place that can be a helpful sort of reminder is that kind of ignoring those unhelpful or ineffective behaviors. We know that that also can decrease those behaviors. So really focusing more on creating the positive attention towards the behaviors we want to see more of.
Great. Do you want me to take this?
Yeah.
Okay, so so let's take this back to how does reinforcement sort of start somebody off in developing the pattern of addiction? And we said at the beginning that stimulants have a slightly different effect on the brain, even though we know that this focus on reinforcing the behaviors that we want to see is going to be effective with humans in general, regardless of what substance they're using or not substances they're using, right? That reinforcement just works. But in terms of how stimulants are affecting the brain, we know that there is a process of conditioning that is occurring. And those of you are probably familiar with the term triggers. So essentially triggers are anything that is going to create a response connected to it. So if we think about it within substance abuse, there's always a trigger or something external to the person that over time has become linked to particular thought about using, and that is linked to the experience and the physiological component of craving, which precedes any use behavior. And we can go back to Pavlov's dogs to explain how this happens. So this was an experiment that was conducted a long time ago that was able to show that we can link things that wouldn't normally elicit a response with something that would elicit that response. And over time, the neutral stimulus will basically be the conditioned stimulus. So what they did was they took a group of dogs and they showed that they're going to salivate when you expose them to food. It's something naturally that they do. So in our brains, when we put cocaine in it or we put methamphetamine in it, we experience euphoria. We have a whole slew of experiences that are very predictable that are part of that drug's response. So that's sort of like our food in this scenario. Now, what they did in this experiment was they linked a whistle or sound that has nothing to do with eliciting salivation, and they paired it with the food. So those things became tied. And over time, they were able to just blow the whistle and the dog would salivate. So that's exactly what's happening in a person's brain is over time, there are these hundreds of triggers, external cues like the whistle, that were totally neutral beforehand, but that are now intertwined with the experience of being intoxicated on the drug to the point where now that neutral thing, the street that was not tied to their use before, or the foil or the syringe, whatever that thing is now its own, will elicit the same physiological response that the drug, having the drug in their hands will. And so that's really problematic because now we have thousands of things that are going to cause cravings and urges to use that hijack a person's ability to really manage that stuff and to delay gratification, to make decisions about their future, to sort of say, I'm not going to give in to that. Because it's a primal part of their brain that's being hijacked. And so this happens over time and also causes shifts in how the person is thinking, right? So we had that there's a trigger, and then there are a set of thoughts connected to that trigger, and then there's a craving and eventual use. So over time, the substance or the alcohol or drug is on the positive side at the beginning, right? So when we first start using, it can provide a lot of relief. And this is called the coping mechanism theory of addiction, which is essentially, I want to use to feel better because I feel bad. Something is going on in my life, or I want to make improvements, particularly with stimulants. And one of the things that we see a lot in MAT programs is people will develop a secondary methamphetamine use disorder because they're coming in with an opiate use disorder because that is a depressant and they're spending a lot of the day with very low energy. They will add meth to their regime to have an increase in energy, to be able to clean their house, to be able to take their kids to work on time, just like how we might use coffee in the morning. And so it's understandable that in the beginning there's a lot of positives to it and very few negatives. Even though the negatives are there, they're not necessarily overwhelming it. Now, over time, this starts to shift, right? We start to see there's still positives, but then the negatives start to weigh heavier. And then eventually towards the end, we see that yes, there's still relief from these things, but a whole host of negative consequences associated with it. So this is showing that classical conditioning piece, that there is a neutral environmental stimuli that gets linked with how the drug affects the brain, and then there's a whole host of unconditioned responses connected to it. Over time, we can remove the drug completely, and the triggers themselves will cause that compensatory reaction to the drug. So that has a lot of implications. It has implications to how we speak with patients about addiction, and it has implications to us about how we think about treating addiction, right? Particularly stimulant use disorder. So what we want to be shifting away from is any of the sort of moral, stigmatizing stuff where we're saying, you know, this person is in denial, they just don't have enough, they're just not motivated, they're not ready, because it really has nothing to do with willpower or the intention to recover. That if they're showing up at your doorstep, they want recovery. They are experiencing that huge list of negative consequences. But what we want to be communicating to them or messaging to them is that their brain has developed a conditioned response, and that insight about that isn't necessarily sufficient to change it, that we have to approach this from a behavioral standpoint, that we really need to help them begin to identify what their triggers are, both internal and external, and develop a skill set to be able to stop those triggers. And then we want to create structures around that new learning to be able to support the change in behavior. One of the reasons why people have difficulty accessing some of these typical harm reduction relapse prevention interventions is because stimulants will erode the frontal cortex's ability to learn some of that stuff or to participate in treatment long enough to learn it. So where contingency management comes in is not only to start to help them learn through those schedules of reinforcement more positive behaviors and shift that balance, but it's also to incentivize the behaviors, the target behaviors that we want to focus on to keep them in treatment and help them to be successful in treatment. And that's why we said at the beginning, this is really such an important linchpin to any successful substance abuse program, because we have very high attrition rates. We lose patients frequently, and when they drop out of treatment or they're not successful in treatment, we all know what the outcomes can be. And so contingency management is one of the most effective ways that we can actually keep them coming back and doing some of the things that we know are going to help them to change how their brain is functioning. So now let's focus specifically on what contingency management is, now that you have all of the foundations of it. I love this cartoon. It's the only way I can get myself out of bed. I would put a cup of coffee there. I would put. So what is contingency management? Do you want to take this?
Sure. Yeah. So, as Dr. Maley just mentioned, it's a program that makes sober living and, all of the actions that are going to be needed to move a person into recovery a much more attractive option by creating some motivation through the incentives, and really by using that positive reinforcement related to their abstinence behaviors and other behavior changes, including, actively engaging in the program. So some of the processes of moving towards abstinence might include like going to therapy sessions, going to skills academies, going to the different things that we want to see them do to build the skills in order to actually become abstinent. So this is really a great way to add that incentive. And I think one of the things that I think will definitely might come up in the discussion is one of the common myths about contingency management is that it's this sort of external motivator that's sort of applied, and you're giving, you're rewarding behaviors maybe that you would hope that they would have quote unquote intrinsic motivation for. But if we think back to that learning theory and that conditioning process, the idea is if we can actually boost up some of that make it more attractive to be sober, then eventually over time that will be paired with some of the intrinsic motivation that naturally comes from making positive behavior changes. So we're going to kind of go into that a little bit more, but I just wanted to sort of also mention that, because that can be oftentimes a first reaction that people have to hearing more about kind of rewarding behaviors that we want to see more of. Awesome. So as the Pavlov and the dog experiment that Dr. Maley mentioned was reviewed, this is the same sort of concept that, behavioral scientists have found that, if you want someone or an animal to change behavior, then basically you want to pair that with other things that can help encourage those behaviors. So this is an example of if you want to encourage a mouse to access the food lever, then basically you would want to provide reward every time he pushed the food lever. So you would give him a kernel of the food. And then over time, he would learn that the liver is what actually produces the food and be more likely to do that. Then there might be another way of also shaping behavior, which is applying a consequence or a shock if you wanted to reduce certain unwanted behaviors, for example. So we can certainly use both positive and negative consequences, but as we're going to discuss next, the thing that actually what the research shows again and again and again is that the rewards the effects of the rewards are much more pronounced and they're much more longer lasting. So yes, punishment and sanctions can certainly decrease undesired behaviors and they do work, but the effects of the rewards are much longer lasting, and that's because of the way that functions to kind of generate some initial motivation and interest, and then over time is then paired with that intrinsic motivation of making those positive changes. So there's all sorts of kind of connected effects that kind of come through over time when rewards are paired with those healthier behaviors.
Well, and I think just anecdotally, we all know that if punishment really was effective, we would have no patience, because the substance use is still criminalized. There is a whole host of negative consequences associated with abusing substances, particularly stimulants, both physically, socially, psychologically to the individual. So that's not sufficient in most cases to help people change once those things have been paired in their brain. So that's why I think it's really important to highlight contingency management is really going to err more on the side of how we shape behavior by rewarding the behaviors that we want to see more of. So not thinking about how we can punish more effectively, but how we can essentially reward in a much more targeted way. Okay.
Awesome. So in terms of kind of like those behaviors that we want to see more of, oftentimes when you're creating your contingency management program, you want to be very specific about what we're calling kind of behavioral targets. So for example, you might incentivize, we do a points system that we're going to talk about in a little bit, but you might want to provide points, for example, for attending counseling regularly. You might also want to provide points or rewards or prizes for, basically having, for example, like on-time payments if they are on a payment plan. And then you want to find ways to, this one here is drug use during treatment. So obviously you want to de-incentivize drug use during treatment. So one way to do that would be how one of the things that we do is for when we have an expected UA or urine, then they also get a point. So that is incentivizing non-drug use as per a laboratory test, for example. And so one of the things that you want to be thinking about as you're considering rolling out a program like this is there are lots and lots of ways to do rewards. Obviously, as Dr. Maley mentioned, there's going to need to be a budget, but you can certainly provide vouchers or money. For example, we provide bus passes. There also might be additional privileges related specifically to their treatment. So, for example, here is the methadone take-home doses. So if they are meeting the behavioral targets of, going to counseling, going to the skills groups, doing the things that we believe are going to set them up for success, to maintaining the abstinence, then they can be earning certain privileges related to making that treatment process a little bit easier for them. Also, opportunities to win prizes. So there are two specific techniques that we're going to talk about called fishbowl drawing as well as lottery. And basically the idea being there are ways to provide those sort of immediate rewards through these point systems, but also have some increase the novelty by creating some opportunities to have access to more of like a lottery, or yes, you have 1 point and now you can draw a reward, and the rewards could either be really big or just a small reward that you might get for that 1 point.
Okay. Did you want to talk about this?
I think that's you.
Okay. Then it's me. Okay. So we were saying, like, there are multiple methods that fall under the contingency management umbrella, all in the emphasis of reinforcing target behaviors. And one of the methods that has been well researched is to use either a voucher and incentive-based or prize-based method. So that means if the patient expresses the target behavior, so we can use the example of making their scheduled appointment, then they earn a point toward a voucher. And that those vouchers could be anything that your clinic or agency might apply. Those could be vouchers for gas or food or things that they would, or Walmart gift cards or things that they could put toward buying presents for their kids at Christmas, whatever it is. But it's similar to why we show up for work every day. Like we are showing up to earn the money to maintain our living. And so we're trying to incentivize that if they do what we're asking them to do, then for every one of those target behaviors, they will earn a point toward a larger prize or a voucher to be able to redeem that prize. And so here is an example of that that showed the number of weeks in treatment and the difference between the standard practice, so the treatment as usual, versus a voucher-based contingency management program. And this was particular for patients that were abusing cocaine. So looking at those with negative urines for cocaine, you can see it's a pretty clear difference, particularly at the beginning of treatment, that it tends to be very helpful for those early on in treatment, and it does have kind of a slowing down or a plateauing of its effect as someone begins to make progress in treatment. But even so, compared to the standard of care, you can see that it really is the voucher or incentive-based approach effective. Another one is called the fishbowl method. So that is similar to the voucher method. This is where someone will elicit a target behavior. So that would be, I show up to my appointment, and they, instead of getting a point towards something, they get the opportunity to win something immediately. So sort of like drawing from a fishbowl, or like a bingo wheel, or just something that allows them to be able, for every behavior, it's an opportunity to win something. Now, out of that fishbowl, there's going to be variability in the weight of the prizes. So you could have something that's like an inspirational message, or you could have something that is like a candy bar, or something that's like a bus pass, or it kind of goes up in terms of the value of what they might win. But there are lower percentages of the higher value items and higher percentages of the lower value items. So, so this tends to be good in terms of incentivizing the target behavior and being able to reinforce it immediately. So rather than someone getting a point and then having to wait until they've accrued enough points to apply for whatever it is that they're going to use that voucher for, they're actually getting something in their hands as soon as they elicit the behavior, but we're not rewarding all things equal. So this is similar to how the lottery works, right? Like we put our money in and hope that we get something really big, but statistically we're likely to either get something very small, right? But yet it's still something. And so I think that's the benefit of the fishbowl method. And what they found in studies on applying this particular method is that it can be very helpful, particularly with retention. So you can see here, the pink is the contingency management, and the yellow is the treatment as usual group. So sort of at the beginning, opposite to the point-based voucher system, it tends to be kind of almost equal in the early treatment, but then as treatment goes on, it has a little more weight to it. So that's just, but still there are clinical differences between using a contingency management fishbowl approach compared to treatment as usual. This is the same study looking at UA results, so the percent of positive results over time. And so you can see, again, pretty significant effects by about 2 months into treatment. The contingency management of the fishbowl approach, pretty effective at reinforcing abstinence or non-use. So how does this really, how can we apply these things to the clinical picture? How can we start to fit this in to our standards of care? It's something that can very easily be added to whatever intervention it is that you provide. So if that's therapy or med management or case management, whatever the patient is showing up for, reinforcing that is low-hanging fruit, right? So really being able to enhance their retention in treatment and their motivation to maintain in treatment. It can also be very effective at helping to sustain abstinence, so reinforcing non-use, as we said, or having a negative UA and reinforcing those. It can also be something that you apply to positively recognizing and reinforcing successive small successes, right? So as people sort of progress in treatment, being able to recognize and celebrate those small things. This is one of the reasons why AA has day chips, right? It is a small way of reinforcing those steps that a person is taking along their recovery journey. And you can use contingency management to do that. In fact, those chips really are part of that taps into that learning theory that we've been talking about. So that's another way that you can just continue to celebrate those small changes that people are making. It has been shown to have really good effects, and it allows for the treatment program or the therapist or the medical provider that's working with the patient to be able to provide a counter to their unhealthy behaviors of substance use. We know that people don't change in a vacuum, and asking somebody to just stop is not very helpful. Replacement behaviors are the most effective thing that we can do, and so by utilizing an incentive-based, a point-based, or even the fishbowl technique to reinforce what it is we're asking them to change, really all we're doing is creating a world in which they aren't just stopping, right? They are stopping and they're getting something for stopping. And over time, that is going to translate to bigger picture positive results like working, right? Like going to school, like making some of those bigger changes that we would expect to be reinforced. Here is another study that shows a difference between the percentage of negative use using a abstinence-based incentive program versus treatment as usual. And here's another one showing you the difference between incentive-based and treatment as usual in terms of those that are maintained in treatment. So again, really focusing on utilizing these approaches to help folks keep coming back and getting the good stuff that you already offer is the real value of contingency management. It can dramatically improve client outcomes, retention, and use while in treatment if applied correctly as part of an overall program. Here's a video that we're not going to watch. It's only about 3 minutes, but it's worth checking out, and you'll have the link in your slides. And it was a study provided by Johns Hopkins, and I think what they were able to do here was take sort of the point-based structure and apply it to progressing into work, right? Which is really cool to be able to see how, again, it translates both from how they're being incentivized early on in recovery and in your clinical program, and then being able to shift that to what that means in the real world. Because if you think about it, we deal with contingency management all day, every day. I mean, it is what probably got us to get through school, or what gets us to get out of bed in the morning when it's really cold out and we have a cold and we still show up anyways, right? So there are things that we are working towards that are our rewards that we're just trying to help our patients eventually translate into that. And so that study is pretty cool to be able to see how they were able to bridge that gap. So now we'll wrap up by talking a little bit about the ASEP program and how we worked to have 2 target behaviors, and how we integrated both the fishbowl technique and the point voucher program to be able to capitalize on the effects of both of those approaches. So this is a graphic that we put together for patients to be able to say, after you provide a negative UA, or when you attend a scheduled appointment, and that could be any appointment that you're supposed to show up for, your therapy, your medical appointment, or a group appointment, you get to make a decision. You can either pick right away from a fishbowl, and you get a chance to get a token. And we were very clear about saying, so you could either get a saying, could be like a small thing, a medium prize, or kind of a larger prize. But it's not a guarantee you're going to get something. So that's option 1. And then option 2 is you can bank your point to be able to earn an even bigger reward. If you choose to bank your points, we're going to help you keep track of that, so that eventually when you earn enough, you can decide to close out and you can redeem any of the prizes that we have available. And we actually have a case in the main lobby that highlights a bunch of the things similar to kind of Chuck E. Cheese, like we have different levels, right? And I don't know if you want to talk a little bit about that, Ali, and how we've organized that.
Sure. So we started with a large amount of inventory, and I think a couple of things you have to consider when putting together some of this inventory for contingency management is figuring out how you're going to price your inventory. And thinking about how many points and how useful those items in particular are to the clients, what the clients have requested as well. So I know at one point we sent out kind of not a needs assessment, but a survey of requested items, what clients would be interested in having in the case, so we could represent that. And then also thinking of your clients really as customers, and thinking of what does your customer base want in their life, need in their life, and then also what might be helpful for them to have to attend treatment. So some of those items being like bus passes or agendas, so clients can keep track of their appointments. We've had requests for baby wipes. There's a lot of babies that come in the clinic with their parents. So things that be useful, and then also a good balance of those kind of more immediate reward, lower point items, so that candy, things that will give you an immediate response and reward. And then also creating some of the larger items that may take many, many weeks or theoretically months to gain enough points so you can really work towards that big prize for your family. Mm-hmm. So just kind of thinking about your inventory, and also then how you're displaying the inventory, if the clients can see the product, if it's customer facing, if they can get the product in their hands, versus just having photographs or pictures, which don't necessarily feel very real.
And then you've done a good job of cycling the prizes based on theme.
Yes.
You want to talk about that? Because that's been successful.
So part of my random life background is a piece of small business management and visual marketing. So thinking again about your clients really in in many ways are customers. They're coming to get services, but they're also this aspect of contingency management is that they're retrieving products.
Mm-hmm.
And so continually changing out the case. Retail seasons go through the same kind of back to school push, and let's push some agendas and let's push some notebooks. And again, things that are valuable, backpacks to our clients, but also fit with the changing seasons of retail. Because unfortunately, the whole world kind of runs on that at this point. We also did we're doing a big holiday promotional push. So we are also incorporating a raffle for some of our clients that have had that are at a different kind of stage of treatment, a more involved stage of treatment. So we're allowing them access to a raffle for a higher, a more desired prize. And then some of the clients who are newer to treatment are getting a different type of raffle with more immediate gratification reward. And then after the holidays, then we'll change over the case again, redecorate it, and push towards probably a wellness kind of theme as again, most retail kind of flips over to the New Year goal.
Yeah, I think it's been really nice to have some of the themes that you have highlighted, because it seems like that one of the motivating components isn't just what they can earn, but knowing that a fair percentage of at least the population we work with is unemployed and doesn't necessarily have the means to purchase some of these things. They're small things like a pencil pack or gel pens,
pencils,
right?
Yes, Crayola.
But it seems like they're drawn to it as well, to be able to give that as gifts to children, to loved ones, to be participating as a valued member of society in a way that they might not be able to outside of. So in this way, again, it mirrors work. It mirrors why we show up to get a paycheck, to be able to buy the things that add value to our life. And so utilizing a point system like that and being able to, like with back to school, like having little kids' backpacks in there
that was
they
huge.
could get.
That was huge.
To be able to give a backpack to their kid at that point in recovery has value beyond just the thing itself.
We were fortunate enough to get some larger items for prizes like crock pots, some home cooking items, some toasters, coffee makers, things that, again, like you said, will contribute to family and home routine, and just being a part of something kind of larger than themselves that their recovery is also affecting, which is wonderful.
Exactly. Did you guys have any other things to add before we move on to discussion? Okay, that's all we got in terms of the didactic piece.